Right. So lecture number one is going to, in the 12 lead interpretation, is going to deal with what a 12 lead should look like. Knowing what's normal on a 12 lead is really important because you can't figure out what's wrong with it unless you know what it should look like, right? So we're going to hop right into it. And looking at this piece of paper here, first things first, you need to establish what rhythm the patient is in. This is important because some interventions need to be done before you even do the 12 lead, and the rhythm should really be established before the 12 lead is even done. And one of the first things that you'll see when you print off a rhythm is what the computer thinks the rhythm is. So the first thing you should do is just go ahead and ignore that right there for right now. You're already going to know, you should know. So we're just going to ignore that. Sometimes that is wrong. So you don't want to rely on it. Don't use it as a crutch. The next place I want to kind of bring your attention to is going to be in the middle, right along here. Okay. Now, this area right here is going to have some numbers that you're going to be familiar with, or that you should be familiar with. Okay. First one is right here. This is your PRI interval. Okay. Again, beginning of the P wave, start of the QRS should be 0.120 to 0.200. Okay. There's your PRI. Over to the right of that, you have your QRS duration. So 0.08 to 0.12. Again, is normal ranges for that. Then we get down to some more probably less familiar numbers. You've got your QT interval or QTC, which the numbers are displayed right over here. Okay, now the difference between the two numbers, QT, which is the number on the left, that is not adjusted for the patient's heart rate. Remember, the QT interval is the beginning of the Q wave, end of the T wave, and should that number get really long, your patient might go into a dysrhythmia that's going to probably end up killing them or end up having you do a lot of work to save him. QTC, which is the number on the right, is adjusted for the patient's rate. The computer goes through a pretty complicated math formula to determine these particular numbers. And without going into detail, since you're not in math class, QTC is going to be the number that we usually rely on. It is most accurate if the heart rate is at about 60, and it kind of degrades if you go in either direction. But the QTC is the number that we're really going to focus on and establish. And we'll talk about those ranges, in the future here. Now, the only other numbers I'm going to draw your attention to are going to be the bottom row right here, which you see the P, QRS, and T axis. This is going to be your axes, for axis deviation, okay? And they correspond to the numbers over here. There's your P, QRS, and then your T. Good news is I don't worry about the P wave. I don't worry about the T wave axis. The only thing I care about is the QRS. So when you look over here, you can ignore that number. You can ignore this number and just point all your attention to this number. When I ask you what the axis is, that is the number that I'm going to care about. Okay, and we'll talk about what those numbers are in a later video, but that's where I'm bringing my focus to. Okay, so that is the middle information presented on the 12 lead. So a lot of numbers in there, to look at. And then we get to the bread and the butter of it. So we are going to look at our 12 leads or our 12 points of view, right? There's 12. You got 1, 2, 3, AVR, AVL, AVF, and then V1 through V6. Now, what I'm going to do is talk about some of the things that you need to know going into it. First of all these leads are different angles. They're different points of view on the heart. They're looking at a heart from different angles. And again, we're only looking at the electricity. How is the electricity traveling through the heart? Is it going towards one of these leads? Is it going by one of these leads? Is it going away from some of these leads? And that's really what's going to determine what you see. Remember, positive wave of depolarization going to a positive lead is going to make a positive deflection on your QRS, or on your waves. Sorry, not just the QRS. So when I look at these, I look at them in groups, and this is the way you kind of need to look at it. I'm going to start off lead 1 right here, lead AVL, and then lead 5 and leads V6. They all look at a similar area of the heart. They all look at the left ventricle from the side. Okay, so like kind of if you raise the armpit up a little bit, that's, if you imagine, that's kind of generally where you're looking at. You're looking at the side of the heart right here. We call those the lateral leads because they are looking at the lateral portion of the heart. Okay. Now they look at it at different angles, but they're all pretty much on the side of the heart there. And then we're going to look at 2, 3, and AVF. These are your inferior leads. Inferior because they look at the inferior portion of your heart, and that is the bottom. Okay. A lot of times you'll see sometimes people draw a little foot there. I'm going to draw that with a mouse as best I can here, but there's your foot for, inferior. Got some toenails there. And four toes is, it's good stuff. So those are your inferior leads. And then grouping the rest of them, okay, you have V1, V2, V3, and V4. Now, depending on what you read, some V1, V2 are generally considered to be septal. They look at the septal region of the heart, so the area between the ventricles and kind of between the atria and the ventricles, really. And then V3 and V4 are going to be your anterior leads. So basically the front of the heart. And when I say the front of the heart, I am talking about the left ventricle here. All of these leads are looking at the left ventricle. Okay, so 2, 3, and AVF, we're looking at the bottom of the left ventricle. 1 AVL, V5, V6, side of the left ventricle. V1 through V4, front of the left ventricle. So looking at these, this is how they're kind of grouped up. This is going to become important later when I talk about looking for heart attacks and stuff like that, because these leads, as they're colored, are what they call contiguous. Contiguous in this context generally means that they are in the same area. They're kind of like together, looking at the same place. So just kind of take that, kind of burn it in your brain here. Now, I know you want to like, well, hey man, what's AVR doing? For the intended purposes of grouping these, AVR is by itself. It's kind of doing its own thing. It's looking pretty much at the top left corner of the heart, kind of where the atria are there. So it's kind of out of the context there, but we'll talk more about that later. Okay. So that's how the leads are usually grouped. That's kind of one of the things that we look at. Now, a couple other things I want you to know and remember is that you'll see essentially like columns. Okay, so this is one column here. This is another column right here. There we have another column. And then another column. Each one of these columns, at least on the LifePak 15 and 12, which is what a lot of you are using, is the same moment in time. Okay, same moment in time. So this is one moment in time, like all this together. And AVR, AVL, and AVF are a different moment in time than 1, 2, and 3. Lead 1, 2, and 3 that's the same three heartbeats that you're looking at right there. Okay, and all those just at different angles. Okay. So that's good because if for some reason, let's say like lead 1 is really I got a lot of artifact, can't really tell and make out what's going on. You can look in lead 2 and 3, and maybe you got a better point of view of what's going on in the heart. It's just kind of a little pro tip for you right there that you can enjoy. So aside from making sure that the rhythm is beating right and the access is good, again, we'll talk about here later. The only other thing I want to look for is in the precordial leads. So when I say precordial leads, I mean your V leads. So everything right here. If you thinking about 12 leads and doing certain things with them and understanding them truly, you really know how the wires are wired. So V1 through V6, these are precordial leads. These are the ones that go on the chest. That's their label, right? You see them on the sticker on the wires themselves. While leads 1, 2, 3, AVR, AVL, AVF, these are your your limb leads. So lead 1, that's your right arm and left arm. Lead 2 is made from your left arm and left leg. Lead 3 is made from your right arm. I'm sorry. Lead 2 is your right arm, left leg. Lead 3 is left arm, left leg. AVR, AVL, and AVF, they use the monitor and the left arm or the left leg and the right arm as it's kind of the thing that they use to make the picture. But we'll kind of talk more about them specifically later. But back to the precordial leads. These precordial leads, there's one thing you should look for in this, and this is the R wave progression. Okay, R wave progression. So each time, or like V1, you see here pretty much a QS wave. And again, based off the isoelectric line, it goes down, it goes back up. That is a QS wave right there. You can sometimes see a little bit of an R wave. That's fine, but for the most part, you are seeing a QS wave. V2, again, drawing the isoelectric line here, you see a mostly S wave right here. You got a little bit of an R wave, a little bit more prominent of an R wave than a V1. Sometimes it's just a QS wave. That's fine. V3 and V4, you see a biphasic wave. Not so much in V4 in this one, but it's not uncommon to see one like biphasic, like V3 is, where it goes up and down pretty much equally. And then in V5 and V6, you have pretty much just R waves. So they go up, and that's pretty much the only direction to go. This is what you should see. So just to kind of clean it up a little bit, that's what they call an R wave progression, a good R wave progression. That's something that I'm looking for here. Okay. So you'll also notice here on the right side some numbers that are printed out, which is fine if you want to use them. It's kind of hit or miss as far as if they're being used or whatever, but and not all of them print that out, just so you know. But those are pretty much the big things that I look for. That's going on in a normal 12 lead. That's something that you want to look for. So, R wave progression here in these leads, as far as the limb leads go and what they should look like, most of them should be upright. And when I say upright, an R wave, maybe an RS wave. Sometimes you have Q wave, but that's usually not normal. I'm not saying it's pathological, but most of the time you don't have it. AVR should have a QS wave. AVR really should have an upside down P wave, an upside down T wave, and a QS wave. That's normal for AVR because of the angle that it's looking at, which we'll talk more about and get to the access videos. But it's okay to see, like, let's say AVL is down, but the rest, most of them should be upright. That's normal to see. And that changes based off the angle there, but we won't go too deep into that. Just kind of want to put that stuff on your radar of things that I'm looking at. I'm looking at, when I look QRSs on these things, I'm looking at what is their dominant direction. Is it mostly up, mostly down? Looking how that changes from lead to lead. Of course, my numbers for the rhythms and stuff like that. And then, some of the numerics. So this, again, is a normal 12 lead. That's kind of the layout of the paper, some of the things I look at on the paper, and we will talk about more specific things in the next video. Very exciting.